In my case, I feel that one of the areas that I was let down was in terms of discharge planning. So the first time, in between one of my admissions, I ended up being discharged from hospital within 24 hours of arriving. And when I had arrived, a previous service had recommended ECT, and the planning had been quite appropriate and sounded sensible and well thought out. When I was transferred, I was there because of being in a different health area. When I arrived, I was discharged very promptly, and little, if any, planning. I didn't have any referrals in the community, and there wasn't a clear plan about how we were to navigate the path forward. In my case and in my family situation, it led to a significant trauma, and it forever shaped our lives and had a terribly negative impact. And it resulted in another lengthier admission, which pleasingly at that time I did receive much more appropriate care. But in that instance of being discharged so promptly and without the appropriate plans and conversations in place, it was catastrophic in my situation.
So Amanda spoke really strongly about being let down with regards to her discharge planning. I think one of the important things when working as a registrar on an inpatient ward is that we need to think about discharge planning from very early on in the admission. That starts by taking a collaborative history from family members and from other healthcare providers, particularly GPs. I think GPs are often left out of those discussions and those considerations. Communicating with those members consistently throughout the admission, and then making sure that discharge is done in a collaborative way. That helps us understand why patients came to hospital in the first place. It helps those other partners understand why certain decisions are made in those patients' care, and it helps prevent readmissions. Readmissions to our hospital system are really costly. They are traumatic, as they were in Amanda's case, and they're unnecessary if we can provide good quality patient care as much as possible. Care in psychiatric services doesn't end in hospitals, it continues in the community. But for that to happen, discharge planning needs to be very collaborative and it needs to be done in a very multidisciplinary fashion.